great to be back here. Thank you all to continuing to come out and to the Park family for organizing these events. And so maybe and tonight I invited Dr. Curry to come with me because I do collaborate with him a lot on these immunotherapy trials. So I'm going to let him talk a little bit later about immunotherapy and where we are in immunotherapy. But I'll just set the stage a little bit and just jog your memory about sort of what we're facing. And really what we have been focusing on in our research is treating patients with glioblastoma, because this is the most aggressive and incurable primary brain tumor. It's fairly rare in the landscape of cancer, with only about 10,000 cases each year in the United States, so it doesn't get a lot of press and a lot of interest. And the way we treat these is with surgery and radiation and chemotherapy. But despite this aggressive therapy, the median overall survival is still only about 16 months. And since 2005, we've only had 2 drugs that were FDA approved for this tumor. So clearly there's a lot of work that we need to do and a lot of effort that needs to go into finding better cures for these tumors. And so that's where we have been really trying to build up our research program and continue our research efforts. And a lot of you may have seen this PBS expose, the 60 Minutes, about the Duke study using an activated polio vaccine to fight brain cancer. And it was a really promising study, but it was a small study, and it was one of the interesting ways of using immunotherapy to fight this kind of tumor. And it's challenging. There was a question that I got last year about how can we get academic centers to work together, and that the Duke did this very promising study, but why is that not open at MGH? Why are we not collaborating more? Why are these academic centers working as these individual silos? And I think a lot of it boils down to the complexity related to these individual trials and how difficult and challenging it is to really get these drugs to work in a feasible way and really to better understand how the immune system is working. And you have to start somewhere, so the Duke study was a good start, and I hope that it will pan out and will be an interesting, promising technique. But the challenge, after they came out with this study, they had 3,000 referrals to Duke for people interested in participating in this study. But of those 3,000 people, only about 15% of patients with glioblastoma are actually eligible for that study. So it's a very small population of patients that would potentially benefit from that type of therapy. So there's a lot of interest in looking in other ways of using the immune system to really try to fight these tumors. And so I think we start off in our silos, but then we try to build on that and will eventually expand to other centers. And so maybe at this point I'll turn it over to Dr. Curry, and he can give you and I a better sense as to where we are in terms of immunotherapy, since he really is a leading expert and has run clinical trials with immunotherapy and novel drugs, and there are many different ways of revving up the immune system to fight cancer. So I'll let him take over.
All right, well, thanks, Elizabeth, for kicking things off. And I want to thank all of you and Bill in particular for having us and for putting on this event, and also for the race, the run walk that you put together every year. I know how labor intensive that sort of thing is, but keep it up, because not only is it a great tribute and legacy, but the generation of funds like that is really important for us, and for the field in general. Like, every dollar literally counts. The NIH or big industry, big pharma fund studies at $500,000 to $10 million per study, but you can't get an idea going without that seed funding that really only comes from foundation and philanthropy. So, like I said, every dollar lets you hire a research assistant to pursue a project that would otherwise lay fallow. or to hire a research coordinator that you need to get a study going. So thank you very much, and thanks to all of you for being here tonight. I wanted to take this opportunity to kind of define the landscape of cancer immunotherapy in general, and then just talk about how it applies to brain tumor therapy specifically. Cancer immunology, manipulating the immune system to attack a patient's brain tumor, is the hottest thing in oncology today. The impact that these novel therapies have had, in particular in patients with melanoma, lung cancer, these diseases affect millions of patients every year. Renal cell carcinoma, almost every week there's a new FDA approval for the use of an immune active drug against some sort of advanced cancer. It's better than anything we've ever seen in the field. I've been working in understanding how the immune system responds to tumors, in particular brain tumors, since 1999 or 2000. And there was always a lot of skepticism about whether or not these treatments could be effective or strong enough, if they were targeted enough. But really the tide turned maybe in 2010 with the first drug called Yervoy, now called Yervoy, also known as ipilimumab, which activates the immune system kind of generally, but extended survival in patients with advanced melanoma from 4 months to 11 months. Or 5 months to 11 months, which doesn't seem like much, but it's unlike anything that ever happened before. And more than demonstrating a principle that we could do this, it also was really meaningful for survival and quality of life. It was a great launching pad. Since then, other drugs that work in a similar manner have gained FDA approval, also for melanoma, in combination with other drugs. And we were seeing, one thing about immunotherapy is that not only do we get an immediate response, but it lasts. The tumors don't develop resistance like they do to chemotherapy or to other what are called molecularly targeted therapies. It really lasts in some of these patients. To understand all of the branches of immunotherapy and the mechanisms, you have to know a little bit about the immune system. The immune system is really, it's a miracle how it works. You think about it. If a virus or a bacteria or a foreign body, like a piece of wood, gets into you systemically, your immune system immediately recognizes it, mounts a response, and rejects it. Organs, right? We all get vaccinated as kids, activating the immune system against very specific targets. And the words we use for that are diversity. It can recognize a lot of different things, and specificity, like very specifically. And we don't reject our own organs. So if you grow a cancer, like, why doesn't this fine-tuned system recognize it and then reject it? That really should be the case, because when you're a fetus in development and when you're a little baby, your immune system is building up to recognize all these external things and to not reject itself, basically. It comes down to, we've learned over the last maybe decade and 5 years, it's almost like a process of natural selection for the tumors. So it's probably the case that tumors are always trying to form. Everybody in this room might have little cellular changes that could potentially develop into a tumor at any moment, maybe 10,000 events a day, actually, in humans. But through a number of mechanisms, the cellular machinery is able to identify these genetic mistakes and shut that cell down. And those mechanisms include immunity. So elements of the immune system can kill off these things that want to become tumors, and they do all of the time. But like a virus transforming, cancer cells in the right conditions can become very smart and develop an ability to either avoid or actually suppress the immune system. We take this to patients with brain tumors, malignant brain tumors, glioblastoma. And by the time that is growing in a patient's brain, the immune system can't detect it. It's cloaked fully. One way that we have measured that it does this is by, for instance, killing off some of what are called T cells. If you look at the T cells in a patient with a newly diagnosed glioblastoma, never been treated, never gotten chemotherapy or radiation or anything like that, if you look at in their blood, their T cell count is the same as a patient with actually full-blown AIDS. So those patients are fully immunosuppressed, and the tumor is directing that. If you take out the tumor, things bounce back a little bit. So one of the things that I've studied in our laboratory are like what is actually happening. How is the tumor doing this? What's the tumor secreting? Is it specific to brain tumors? How does that impact our ability to employ immunotherapy? Because we need cells. We need the cells of the immune system to kill the tumors. It turns out, and these are very novel findings, I would say, is that both in mice with brain tumors and in human patients, again, with newly diagnosed brain tumors, the cells that you need to kill off a tumor, to respond to a tumor, are actually driven from the bloodstream into the bone marrow for some reason. And we've figured out, I think, what that reason is, or what's coming out of the tumor that causes that. But think about that. That's the genius, so to speak, of a brain tumor, that it can get rid of its enemies, within the circulation. So our next goal then is to figure out a way to either mobilize those effector cells from the bone marrow with medicines, or to actually harvest them like you do in a bone marrow biopsy and grow them out in culture, basically, and then re-inject them so that they're able to now target the brain tumor, just via IV injection circulation. But that's to kind of let you know what cancers in general, and in particular brain tumors, can do to the body. And that's what allows them, one of the things that allows them to grow in the first place. So immunotherapy is a very broad topic. What has generated the most excitement and the best responses over the last 5 years is something called checkpoint inhibition. Going back to the normal situation, if you had a bacteria or a virus or a foreign body, you rev up an immune response. But if that immune response just kept going, you would have a lot of inflammation, you get autoimmunity, you get pretty sick. So normally, the normal mechanisms are in place to shut down, to slow down that immune response. And those are called immune checkpoints. It turns out that in cancer, including in brain tumors, those checkpoints are overactive. The cancer has modified the system so that those checkpoints are overactive. So checkpoint inhibition blocks that, those breaks. In a sense, you have these cells that are able to recognize the tumor maybe, and now that the new drugs release those breaks and let your effector immune cells kill off the tumor. It turns out that they also might kill off some normal cells too. And so that's why there are side effects which are autoimmune. And some drugs are worse than others in that regard. But when you're saving people's lives from cancer, we can manage some of those side effects, with medications and with supportive therapy, and it's worth it. So checkpoint inhibition has really changed the way cancer is being treated today, and it's really standard of care, which is hard to imagine, whereas people outside of the field hadn't heard of it, as little as 3 or 4 years ago. It's probably the most exciting thing I've ever seen in clinical oncology, actually, since I've been a professional. So that's one form of immunology, and this is the one bit of science that I think will be helpful. And this is it's a T cell, and the T cell is that cell of the immune system which kills its target, in this case, the tumor cell. This cell up here is called a dendritic cell, but it's the cell that has recognized the foreign element, and it informs the T cell what to go attack. This antigen-presenting cell, talks to this T cell through these molecules at that synapse, we call it, or at that bridge there. And there are molecules on either side that can be targeted. And these checkpoint inhibitors block molecules on this side. That's checkpoint inhibition. Vaccination, you may have heard of cancer vaccination, is a way of better informing these cells here, these antigen-presenting cells, and telling the immune system what to go attack. Not to attack it better necessarily, but what to go attack. And I think vaccination is the ultimate in personalized medicine. Have you probably heard of the concept of personalized medicine? What we do, the approach that we take, is in the brain tumor patients after surgery, which is of course very good for patients, is to take their tumors, each individual patient tumor, and harvest it and engineer it in such a way that it is now immunostimulatory. We radiate it so that it is no longer dividing, so it's not proliferating, so it's not going to be a danger to the patient when we re-inject it subcutaneously, just like your measles, mumps, rubella vaccine. And then at that vaccination site, you get a big inflammatory response. And the immune cells pick up this material that is your own tumor, and they traffic to the kind of sentinel nodes, or basically of the immune system, and there educate the T cells, which can then circulate around and kill the tumor. And that's a technique that was really conceived and pioneered, maybe 15 years ago, but over the last 10 years has been brought to some clinical fruition. And what we've shown in our brain tumor patients at Mass General, who we've vaccinated in this way, is that we can very consistently and very safely stimulate an immune response against the tumor. We can measure in the blood that their T cells are activated. We generate antibodies against the tumor. And we believe that we get the infiltration of tumors, of lymphocytes, immune killing cells, into the brain tumors. Now, it's very hard to know that for sure, because unless we do biopsies, which are invasive procedures and not appropriate for some of these patients at that time because of the risk, or we take the tumor out again. But I want to give an example here of one of our patients who we treated in such a fashion. He's a 41-year-old patient with a glioblastoma. He'd had several recurrences, and we did another surgery where we took out that lesion you see there. And I just want to focus your attention on the top. And then we enrolled him on our vaccination protocol. And the day we started, this is at week 0 is what his tumor looked like. And he did really well. But at week 5, so basically 4 vaccinations in, he got a headache. He got weak on the left side of his body, on the contralateral side to the tumor. And we got that MRI, which showed an enlargement in what we call enhancement. That's where the dye is taken up by the tumor. And so we made an assumption at that point, this was the 4th patient we had treated, that the tumor had progressed. But we decided to keep on with the therapy. We gave him some anti-swelling medicine to see if we get his symptoms better. We got an MRI 2 weeks later, and this enhancement had shrunken. He felt better, and like the amount of volume that it was taking up in the brain had gone away. And so with this, in retrospect, what we were able to conclude was that he had had an intense inflammatory response to the vaccine. At this point, this isn't tumor progression, we don't think, although we don't know for sure. We think this is the inflammatory cells getting into the tumor and doing what we want them to do. But we would never know that unless we wrote it out, got him more MRIs. And if this had been stable, we would have not known what was happening. I think we would have assumed progression and taken him off of the immunotherapy protocol. Okay? One of the biggest challenges in brain tumor therapy itself is knowing what the MRI means. MRIs are beautiful. MRIs give us a lot of structural information, but in general, they don't tell you what is actually happening in what we call the tumor microenvironment. And that's really the information you need to know if you're to understand what your therapies are doing. The bottom panels here show some blood tests that we ran in an investigative way to try to study the immune response. And we could see, again in retrospect in this clinical trial, that at week 5, we were activating the immune system. And so in theory, if we put that information together for any given patient with this imaging finding, we might say, week 5, the immune system is being activated. Maybe we'll interpret that as immune activity and not progression, and we'll continue on with treatment. But we don't have the tools to really have the answer right now, and a biopsy there would be risky. And so therefore, we need to develop some form of immunomonitoring or clinical monitoring or radiographic monitoring, ideally, to give us some sort of picture at a microscopic level, really, of what's going on with this patient's tumor on the MRI. And that's where Dr. Gerstner's work comes in, and that's where she and I have been collaborating on work that's really supported by you guys, and some of what she talked about last year, I think will update us on this year. So in terms of the overall outcome for the patients in this protocol, we had a number of patients with very advanced disease who lived significantly longer than would be expected. We had a number of patients who lived as you would expect them to, but had good immune responses. So at the end of the day, we need to make this vaccination therapy stronger. We need to alter it, to tweak it, to fine-tune it, to make sure that the cells, the cellular responses that we're generating actually get into the brain tumor and do their work there. And that's going to take a lot of basic science, but may not be as far off as I just made it sound. Because when you combine one immunoactive therapy with another, you have a chance to really make things happen. And this is an example of work that we did in my laboratory in what's called a preclinical model, a little mouse, where we combined the vaccination approach I just described to you with the checkpoint inhibition that we talked about. If a checkpoint inhibitor, ipilimumab or PD-1 inhibition, just to throw some terms out there that are literally in the news almost every day, when you use those, you're relying upon a T cell that already exists and you're releasing the brakes. But when you vaccinate that patient, or that animal in this case, first, you increase the number of T cells that are going to recognize that tumor, and then you unleash those on your tumor. And there's the potential for things to be gangbusters. So this is the study that we did in the mice, where this is a survival curve, it's called, but you can see the combination cured a large number of mice with a very aggressive tumor. And that's the study we're setting up to do next. It's combining vaccination with checkpoint inhibition in about 30 patients, and we should, I think, start that probably by the summer. But that will be coupled with some of the technologies that Dr. Gerstner has been working on and applying in our patients with a variety of different types of brain tumors, primary brain tumors and also metastatic tumors to the brain in patients that are being treated with these immunoactive agents. We can really try to get a handle on what's going on. It'll tell us if we're being effective. It'll tell us who should continue with these therapies and who should come off and go a different direction. So again, thanks for your time and your attention here.
Just a couple more slides to wrap up to give you an update on the clinical trial that I had mentioned last time that you guys are all a part of and are all supporting. And so, Dr. Curry had outlined the clinical dilemma that we're facing, where particularly if you're giving somebody immunotherapy, you see this MRI scan that can potentially look worse, and we don't know if it's really a response or it's progression. We're enrolling patients, and they are going to undergo this sophisticated MRI and PET scan to really try to measure the immune response to treatment. And so we're using this PET tracer, which is called PBR, and it's supposed to get uptaken by immune cells. So we'll be able to measure how many activated immune cells there are in the tumors as patients go through treatment. And so our trial has two arms. This is our first arm, where patients who are getting immunotherapy will have these MRI PET scans done prior to treatment, and then at that time where we have that MRI scan and we're not quite sure how to interpret it. And then we'll be able to see if there's any change in the PET scan to tell us if the immune system is activated or not. And then our second arm will be patients who are just getting standard chemotherapy and radiation, because standard chemotherapy and radiation can also cause inflammation that is hard to distinguish from active tumor as well. So this is our second arm of patients that we're acquiring. They're going to also have these PET scans at that time where we're not sure how to interpret the MRI scan. And so we've consented 5 patients for our trial, because you guys are all a big part of this trial. We've gotten 2 patients scanned so far, and so I just have one example picture that you can see here. This is the area of the tumor here. This is the area that takes up the contrast dye. This happens to just be the picture that doesn't have the uptake of the dye, but this is the area where you take up the dye on the MRI scan. And this is the PET scan. And so you can see that this patient actually takes up our PET tracer, suggesting that this patient has an immune response. And what we're learning as I look through these pictures and we're analyzing them, these tumors are very heterogeneous. And so some parts seem to take up more of the PET dye, and other parts don't take it up as much. And this is something that we know about these tumors, is that the makeup of the tumor can be very heterogeneous throughout the tumor. And so that's one of the benefits of imaging, is we get a picture of the entire tumor itself, and we can see maybe what parts of the tumor are responding, what parts aren't, and maybe there's something else we need to do if there are parts of the tumor that are not responding. So that's where we're at. Thank you, as always, for your support and continuing to come and listen to us talk. We very much enjoy the conversations we have with all of you guys. I certainly learn a lot in my conversations with people at dinner and beforehand, because you always come up with very good ideas. So thank you for your continued support, and we're happy to take any of your questions that you may have.